Got it. So thank you folks for your patience. Unfortunately, we're MDs, not AVs. So I'm Dr. Chris Rogers. I'm the founder of San Diego Orthobiologics Medical Group. I'm joined by my colleague, Dr. Edmund Evangelista. Both of us, even though we look young, each of us have more than 2 decades experience treating orthopedic conditions. And because we've been doing that so long, it means that we started off doing a lot of cortisone injections, corticosteroids. And in the last 15 years or so, we've become converted to more cell-based. But we want to sort of go through the pros and cons of the different options that are available to folks with joint arthritis or tendon injuries or spine injuries. And then so Dr. Evangelista will present some material to you, and then we'll take your questions and answers. A little bit of housekeeping. At the bottom of your screen, you can see an area where it says Q&A. And if you type in your question, we will see it. And then we will answer as many as we can. The time tends to go fast, so without further ado, let me introduce Dr. Evangelista.
Thank you, Dr. Rogers. Let me try to share my slides here. Here we go.
Great.
Okay, so today I'm going to talk about the cortisone injections. As most of you know, cortisone injections are widely used in the field of orthopedics for treating various orthopedic conditions, but I don't think that a lot of patients or even doctors know about the potential risks and adverse effects of cortisone injections. So I'm going to talk about some of those risks and adverse effects, as well as the potential benefits of cortisone injection, when it may be reasonable to try cortisone injections, and then also some treatment alternatives. So just a brief review of endocrinology. Cortisol is a steroid hormone, which is in the glucocorticoid class of hormones produced by your adrenal glands. Your adrenal glands are the small glands just above the kidneys, and these glands release cortisol in times of stress and also to help suppress inflammation. Now, cortisone that we use clinically is a synthetically manufactured injectable drug that resembles cortisol, and we use it in orthopedics to treat inflammation in joints and around tendons. Now, cortisone injections are also known as corticosteroid injections as well as steroid injections, not to be confused with anabolic steroids, which are the steroids used to build muscle. We are using the anti-inflammatory type of steroids to help inflammation. So in orthopedics, we use cortisone to help joint inflammation. So for joint arthritis or joint injuries, we use it for tendonitis, which is inflammation around a tendon. We use it for bursitis, which is inflammation of a bursa. If you recall, the bursa are these small fluid-filled sacs that allow normal gliding motion between tendons and bones. So you have bursa around your shoulder, knee, hip, most of the major joints around your body. And if that bursa gets inflamed, we call that bursitis. And then we also use cortisone for spinal nerve root irritation. So, for example, if you have a herniated disc in your lower back pinching on a spinal nerve root causing sciatic nerve pain down the leg, we use cortisone to calm that nerve pain down, and we call that an epidural steroid injection. Now, the benefits of cortisone injections are that it's a very potent anti-inflammatory, so it can help reduce pain and inflammation. It's relatively fast acting, so most people get relief within a few days to a week. It's readily available and it's covered by insurance. What are some of the limitations of cortisone injections? Well, it's often a temporary fix where it doesn't necessarily heal the underlying injury. Relief is often short-term, so you can have relief for anywhere from a few weeks, and if you get lucky, it can last up to 3 to 6 months. But it's often not a long-term solution for most of the orthopedic conditions that we treat. Now, what are the side effects of cortisone injections? Well, following an injection, it can cause temporary increased pain, after the injection. Although the injection is local, it does get absorbed into the system, so it can cause systemic side effects. So facial flushing is pretty common, mood changes, irritability. People can feel wired for a few days. They can have trouble sleeping or insomnia. It can raise blood sugars in diabetics. We often have to counsel diabetics to monitor their blood sugars very closely after the cortisone injections. It can increase blood pressure. It can suppress the adrenal glands, so your body may be unable to produce the normal cortisol that it may need at a time of stress, for temporarily following a cortisone injection. And then with repetitive injections, it can cause weight gain and even osteoporosis. Cortisone can suppress the immune system, so it may increase risk of getting an infection such as the flu following that cortisone injection. It can also decrease vaccine efficacy, so your body may not be able to mount that immune response that it needs following that vaccine. So we often typically tell patients to avoid getting a vaccine around 2 weeks before and 2 weeks after a cortisone injection, because that vaccine may not be as effective. Cortisone can also increase risk of developing an infection following hip or knee joint replacement surgery. So it's pretty much standard of care that most surgeons will delay doing a hip or knee replacement if you've had a cortisone injection in that hip or knee joint, and they'll hold off on surgery for at least 3 months until 3 months after that cortisone injection. It's pretty much standard of care. Dr. Rogers, are your surgeons that you work with, do they do the same thing? They wait for 3 months after cortisone?
Yeah, that's the experience I have with the orthopedic surgeons I've worked with, where they recognize that increased risk, and that can influence how patients are treated, and how they're managed. If we're considering joint replacement, it definitely goes into the thought process.
Same thing with lower back surgery. Cortisone can increase getting a post-operative infection. If you've had a lumbar spine steroid injection within 30 days just prior to that lumbar fusion surgery. And then it's well known that cortisone is harmful to tendons. Cortisone can weaken tendons and increase risk of tendon tear or rupture. So we definitely try to avoid doing cortisone injection around your major tendons, such as your Achilles tendon, proximal hamstring, and patella tendon. This was an interesting study published in Arthroscopy in March 2019. It showed that patients who received a cortisone injection within 6 months of a rotator cuff surgical repair were much more likely to have that surgical repair fail and need to undergo revision surgery within that following 3 years. And the thinking behind this is that the cortisone has weakened the tendon and the tissue, so it's not able to hold that surgical repair in place. So these patients who have the surgical repair following a cortisone injection are at increased risk of that surgery failing. So I know some surgeons who will purposely avoid injecting cortisone if they think there's a high likelihood that you might need surgery, because if you have that cortisone injection, it might increase risk that that surgery will fail. It's well known that cortisone is harmful to joint cartilage. There are multiple laboratory and animal studies that have shown that corticosteroids are cytotoxic to articular cartilage. And there's a growing body of clinical evidence showing that steroids will accelerate cartilage loss. So let's look at some of that data. This was a study published in Radiology in December 2019, just kind of reviewing the potential adverse effects that you can develop following an intra-articular cortisone injection into a hip or knee joint. And they documented 4 things. One was accelerated arthritis progression. The second was subchondral insufficiency fractures. Number 3 was osteonecrosis, or death of the bone. And then rapid joint destruction, all possibilities following intra-articular cortisone injections. These are 4 separate studies, all published in the medical literature, documenting a condition called rapidly progressive hip arthritis. I don't think a lot of patients are aware of this possibility, but this is a possibility that can happen following a single hip joint cortisone injection. And depending on which study, the incidence of this happening was anywhere from 2.8% in one study up to 21% in one study. And these are recent studies published between 2018 and 2023. One of the studies did show that there was an increase. Now, it can happen with just a single injection, but one study showed that the chance was much more likely if you had repetitive injections into the hip joint, or if you have a higher dose steroid injection. So up to 80 milligrams, if you're having a high dose steroid for the joint, there's more likelihood that you'll develop, that you can develop this rapidly progressive hip arthritis. This was a landmark study, very good medical evidence showing that cortisone can accelerate cartilage loss. This was published in the Journal of American Medical Association in May 2017. It was a randomized controlled trial where they looked at 140 patients with symptomatic knee arthritis. And they had one group of the patients randomized to receive a cortisone injection every 3 months for 2 years. And then the other group received a saline injection every 3 years. And it was a double-blinded trial. So the patients didn't know if they were receiving a cortisone injection or saline injection, and the physicians didn't know if they were injecting cortisone or saline. And they measured the cartilage volume on these patients with MRI to see if there was any cartilage loss over time in these patients. So a very objective measure if there was any cartilage loss. And they found that the cortisone patients who had cortisone injections had significantly greater cartilage volume loss on MRI compared to the saline group, and no improvement in pain. So not only did the cortisone not help their pain scores, but it accelerated the cartilage loss. So very strong evidence showing that this is what's happening. This is another study published in 2019. It was a cohort of patients also with mild to moderate knee arthritis, and they followed patients who either received an intra-articular cortisone injection versus those who did not receive any injections. And again, they showed that patients receiving the cortisone injections were associated with progression of arthritis as seen on radiographs. And then 2 more studies, which have not yet been published, but were recently presented at the Radiological Society of North America annual meeting in November 2022. There were 2 studies. The first study was performed by researchers from UC San Francisco. They looked at patients with knee arthritis, and they looked at patients who received cortisone injections versus patients who received hyaluronic acid or gel injections into the joints. And they followed these patients with MRI over 2 years. And these researchers concluded, they stated, results conclusively show that corticosteroid injections are associated with significant progression of knee arthritis up to 2 years post-injection. And then the second study that was published or presented at that meeting was from researchers from Chicago Medical School, also looking at patients with knee arthritis who received either cortisone injections versus patients who received hyaluronic acid injections or no injections at all. And they followed these patients with x-rays at baseline and over 2 years. And again, they concluded that patients that received the cortisone injections had significantly more osteoarthritis progression. So there's very compelling evidence in the literature that cortisone will accelerate cartilage loss over time. Now, despite all this data, we still use cortisone on a clinical basis. So when is it reasonable to get a cortisone injection? Well, a couple of clinical scenarios where we will still use it. One is if a patient needs quick-acting short-term pain relief. Common scenarios would be an upcoming vacation. They're having pain, they want to enjoy their vacation. So we will try to time a cortisone injection 1 to 2 weeks before the vacation to help get the pain under control for that vacation. Or if they have an important event like a wedding coming up and they want their pain under control, same thing. We do the injection, get them through that event. We tell them that it's not really going to be a long-term fix, but we just want to get them through that event. Another scenario is if a patient has severe pain and they want immediate pain relief. I think the benefits probably outweigh the risks in that setting. Those are probably the 2 most common scenarios where we'll still use cortisone injections. Dr. Rogers, any other thoughts on when you still like to use cortisone?
Well, excuse me, for certain indications, the ones that I see most commonly would be more like the bursitis cases where there's an inflamed bursa, where there probably is a cytotoxic effect on those cells as well, but you're not going to have a detrimental effect on tendon or cartilage. At least we don't think so. The other indication is in the epidural space, as you mentioned earlier, for the patient with acute radicular pain. The primary benefit being that the benefit usually occurs within the first 72 hours. So it as opposed to the other treatments we offer, it's very quick relief, but it's, the trade-off, the lights keep going out, so I'm in the dark now. So the trade-offs are that, you get a quick relief, but you don't get a long-lasting benefit. I think the other thing worth mentioning, maybe we're going to mention it already, is that we typically in our office now have reduced the doses of the corticosteroid that we use, and we still find some clinical benefit from that. So in a lot of those studies, they use a variety of different steroid types, a variety of different dosages, but I have found in my practice that by minimizing the dose, I think I feel better that I'm not creating harm to my patient, and I can still get a good clinical benefit.
Yeah, I agree. A lot of the orthopedic groups are still using very high dose steroids into joints, which is not, it's super therapeutic. It's not necessary to go that high. You can still get a therapeutic effect with a lower dose steroid. I agree. And then when should cortisone injections be avoided? Well, one scenario is with repetitive injections. We see that all the time where I think a lot of doctors still tell patients that as long as you're doing 3 or 4 per year, it's safe. But based on the recent data, it's not safe. We know that even a single injection can accelerate cartilage loss. So repetitive injections definitely is not a good idea. What about a series of 3 injections? That used to be a thing, even especially with epidural steroid injections in the spine. It was protocol where doctors would automatically set up a series of 3 injections, but there was very little, if any, data showing that is the way to treat a patient. And we know now that that's not a good idea based on the potential side effects and risks of these injections. Again, high dose steroid injection, 80 milligrams or more should be avoided, again, because there's higher chance that you can cause accelerated cartilage loss or this rapidly progressive hip arthritis. Unfortunately, a lot of patients don't have any control of what dose of steroids they're going to get, but if you talk to your doctor, tell them you want a low dose steroid. 40 milligrams is kind of a more reasonable dose than 80 milligrams for Depomedrol or Kenalog, which are the most common steroids that we're injecting into joints. If you have an upcoming surgery, you want to avoid cortisone injections, especially into a hip or knee joint just prior to knee replacement or hip replacement surgery. You definitely don't want to do cortisone to help tide you over until you have the surgery, because there's going to be increased risk of infection. Same thing with lumbar spine. Patient who has mild to moderate pain, in that setting, I think there's better options. I think the risks outweigh the benefits for these patients with mild to moderate pain. Someone looking for a long-term solution for their problem, cortisone is not the answer. Cortisone is not a long-term solution. It's usually a short-term solution to get the pain under control. And then if you're treating a partial tendon tear or tendinopathy, which is a degenerated or damaged tendon, cortisone doesn't really make sense as being the correct treatment, because we're not treating a tendinitis, which is an inflamed tendon. It's you have an injured or torn tendon. So cortisone doesn't necessarily help that scenario. So is there a better option for joint arthritis or these chronic tendon injuries? Absolutely. PRP or platelet-rich plasma, I think, is really the better treatment for most of the orthopedic injuries we see. So let's review platelet-rich plasma. So what is PRP or platelet-rich plasma? It's where we take a sample of your blood, we do a blood draw, and then we concentrate the platelets out of that blood sample, typically about 5 to 10 times baseline, using a centrifuge. We place that blood sample in the centrifuge. That centrifuge will separate the different layers of cells depending on their weight. So the heavy cells, which are the red cells, as you can see here on the picture, down to the bottom. That white layer in the middle are the concentrated platelets, and then the plasma is on top. So we take that concentrated platelet layer plus a plasma, and we have PRP, platelet-rich plasma. So we use PRP for chronic tendon injuries, so partial tendon tears or tendinopathy. A lot of these tendon injuries will fail to heal as we age because they often occur in an area of the tendon that has inadequate or poor blood supply. So the body is not able to get those healing factors to the area to heal that tendon. So we can inject PRP and the concentrated platelets, which will release multiple growth factors to jumpstart that healing of the tendon injury. And it's not just a temporary fix because we're actually healing the injury. So it can be a long-term solution for a lot of these partial tendon tears or chronic tendinopathies. For joint arthritis, PRP can be very effective for arthritic pain. It will improve that joint microenvironment by reducing inflammation, decreasing the harmful proteins and cells that cause pain and cartilage loss. It will promote healing of injured areas of cartilage and bone and slow that degenerative process. So it's really reversing that toxic joint environment and modifying the disease process. So if you look and compare it, PRP versus cortisone, I would definitely say that PRP is really the better treatment for these orthopedic injuries that we see. PRP will heal the tendon injury, whereas cortisone, as we discussed earlier, is harmful to tendons. PRP will improve cartilage health, whereas cortisone is now very well known to accelerate cartilage loss. And PRP will give you longer-term pain relief, whereas cortisone will give you short-term pain relief. Now let's look at some of the data comparing PRP to cortisone. Now, there are numerous studies looking at PRP compared to cortisone for different clinical conditions that we treat in orthopedics. So it's nice to look at these meta-analyses or systematic reviews where they will look at multiple studies on the same topic, compile that data, and then analyze those results. So I'm going to review some of those meta-analyses and systematic reviews. So this was a meta-analysis published in March 2023, so this year in Medicine, and it looked at 16 different randomized controlled trials, 1,652 patients with mild to moderate knee arthritis treated with various injection therapies. And they concluded that PRP injections outperformed injections of cortisone, hyaluronic acid, and ozone in terms of pain, stiffness, and function. Here's another study published in September 2021, another meta-analysis looking at 30 different randomized controlled trials, so 3,463 patients with knee arthritis treated with either cortisone, PRP, hyaluronic acid, or placebo. And again, these authors found that PRP injections demonstrated the best overall outcome compared to cortisone, hyaluronic acid, or placebo at 3 months, 6 months, and 12 months follow-up. This was a very good study looking at PRP versus cortisone for a condition called gluteal tendinopathy. This is a very common condition that we see. It's patients present with pain over the outer aspect of the hip. They are often misdiagnosed with having bursitis, a hip bursitis. But when we look at these patients with ultrasound or MRI, there's actually no bursitis. The pain is coming from an injury to the gluteal tendons where they attach at that outer aspect of the hip at the greater trochanter. So this study looked at 80 patients with gluteal tendinopathy, and they compared a single cortisone injection to a single PRP injection. This was a double-blind randomized controlled trial, so the patients didn't know if they were receiving cortisone or PRP, and the doctors didn't know what they were injecting. And they followed these groups over time. Both groups showed improvement at 2 weeks, 6 weeks, and at 12 weeks, but the PRP group was significantly better at that 12-week mark. So 82% of the PRP patients had achieved minimally clinically important difference, whereas only 56.7% of the cortisone group achieved that minimally clinically important difference. Over time, the PRP group continued to improve at subsequent follow-up visits and had sustained relief at 2 years. So it's really a long-term treatment. The cortisone group had maximum improvement at 6 weeks and didn't maintain that improvement past 6 months. So very good study looking at treating this gluteal tendinopathy.
And you're aware that there are studies that go out to 4 years where they're doing one MRI every year for 4 years after a single injection into the tendons of the hip, showing that even though no additional therapies were done, the tendon continues to look thicker and stronger each year. And then add to that our data, we've been doing PRP now for over a decade and a half, and we'll see patients, they'll come back with their spouse, and remind us that we treated them 10 or 11 years ago, and report that they're still doing very well. So like you say, for tendon injuries in particular, PRP is absolutely long-term benefit that I personally have never seen with any other type of treatment that we do.
Yeah, I agree. The gluteal tendinopathy is really, the PRP has been a game changer. Our results that we're seeing are very similar to this study, where we're seeing over 80% success with the long-term treatment with using PRP for this condition.
Yep.
Here's another study published June 2021. It was a systematic review of systematic reviews. So this looked at multiple systematic reviews published between 2016 and 2020, comparing PRP to cortisone injections for patients with tennis elbow or lateral epicondylitis. And they found that cortisone was more effective in the short term for short-term pain relief, but PRP was more effective for long-term pain relief and improved function.
We now call it pickleball elbow.
Yeah.
So commonly seen in pickleball players as in addition to tennis players.
Here's another systematic review meta-analysis published in the American Journal of Sports Medicine, August 2020, looking at 20 different studies, 1,268 patients evaluating PRP versus cortisone for elbow epicondylitis, so either golfer's elbow or tennis elbow, as well as plantar fasciitis. For the elbow epicondylitis patients, they found that PRP yielded statistically and clinically better improvement in long-term pain compared to cortisone. And for plantar fasciitis patients, they found that PRP yielded statistically, clinically better long-term functional improvement compared to cortisone.
I don't know if everybody knows what plantar fasciitis is. It's a fibrous tissue that attaches to the bottom of your heel, and patients who have damage to that structure have trouble walking because of the sensitivity of putting weight on the heel. It can be a very disabling condition.
Yep. And so if you look at all the science and clinical data, really PRP, in my opinion, is really the better long-term treatment for tendon injuries as well as joint arthritis. And I think, once insurance companies catch on, this is really going to be the standard of care, because cortisone is really detrimental to cartilage and tendons, and it's really not the correct treatment for a lot of these conditions that we treat.
It's the most common question we get is why, well, first of all, thank you, Dr. Evangelista, that excellent presentation of the data, and I appreciate it, and I'm sure our viewers appreciate it as well. We're starting to get some questions, which we're going to address here in 1 minute, but I just wanted to address the most common question that I get from my patients is when will insurance companies pay for PRP and some of these other cell-based therapies? And I think the most important thing for patients to understand two things. One is a little snarky comment, and then the other is a scientific point. The snarky comment is the insurance company doesn't want to pay for anything these days. They fight us on practically everything we ask them to cover. But that aside, in their defense, if you look at all the different clinics in the United States that offer platelet-rich plasma therapy, there's a wide variation in how the service is delivered. And so I think this lack of standardization creates some uncertainty. And as you know, insurance companies are all about managing risk and costs, and that certainty would help. So that's why we, Dr. Evangelista and I, and a network of 150 doctors around the country, are documenting the outcomes of our patients, both the benefits and the risks, adverse events that occur. And by maintaining a database of we're up to 15,000 patients now, I think, we'll be able to see the patterns that produce the best outcomes. So if Clinic A and Clinic B have a different way of making the PRP, the centrifuge spins for a longer time or at a higher rate, or they take more platelets out, or they put it in a certain way. Once we identify best practices, which we're there on many indications, then we can standardize that across different clinics. I think that's when we'll see insurance companies start to pay. To be fair, there are some insurance companies who do pay for this TRICARE. For active duty military will pay for platelet-rich plasma, as they should. Some self-indemnified companies will pay for their employees to have platelet-rich plasma. So we are seeing some changes now, but we got to get the big one. We got to get the big insurance companies, Medicare, et cetera, to get on board. And I think a part of that just has to do with the fact that these treatments need to be standardized.
Yeah, and I just find that nowadays the insurance companies are really going the opposite. They're paying for less and less. There's just not enough money to go around or something. But we're having trouble getting MRIs approved that are necessary. Even when we were doing steroid treatments years ago, it's even hard to get a steroid treatment or a procedure authorized. So it's really going the opposite way right now. The other thing is the big medical society that I think need to get on board. I think the American College of Rheumatology, they still advocate for cortisone injections every 3 months, which they treat inflammation. So I think and it does give you temporary relief, but I think the data is very overwhelming that cortisone will accelerate cartilage loss in that joint. So if you're trying to avoid knee replacement or hip replacement surgery, cortisone every 3 months doesn't really make sense because it's going to, over time, make the condition worse.
Yeah, I agree with all those comments. I have to say the positive note is, who's leading the charge in orthobiologic therapy besides the doctors that are developing these procedures, such as ourselves. We really have to pay gratitude to those patients that put their trust in us to spend their hard-earned cash to try something, 15 years ago, we had very little, if no data on. A lot of times it was our professional athletes or people that, put a high value on their health and were willing to invest when their insurance would not reimburse for the care. And those folks, thousands and thousands and thousands of those people have allowed us doctors, not just Dr. Evangelista and myself, but the entire field of healthcare medicine, those doctors that practice regenerative medicine, to evolve in a way where we have now identified the best way to administer PRP to a tendon or PRP to a patient with knee osteoarthritis, or who not to offer it to at all, right? Where we understand where the potential benefit is minimal, and maybe something else is more appropriate. So I'm grateful to all those patients who put their trust in us and allowed us to move this field forward, even though their insurance didn't want to pay for any of it. Okay, let's answer some questions here. The first one is, your description of adverse events was mainly around joint injections, and that's true. That's where most of the data is. How does it apply to an epidural lumbar nerve compression not resolved by surgery? You want to tackle that one?
Sure. Yeah, I think most of the adverse effects that we're seeing are with joints. So we know that it can accelerate joint cartilage loss, and around tendons, it can weaken tendons. I think the risk is less with injecting it into the epidural space just because it's not going into a joint. It's kind of flowing in different areas, or it's not a confined area where it's going to accelerate cartilage loss. There's not any major specific tendon that we're concerned it's going to weaken. I think it's going to cause just general weakening of the tissue. So if you have major back surgery, it could play a role into whether the tissues are strong enough. I think there has been some evidence showing it can increase risk of getting a dural tear. The dura can get very thin and weak and increase risk of tearing during surgery. But I don't really think there's any specific thing we could say that cortisone injection is going to cause you to not improve after decompression type surgery.
Other than what you already mentioned, there is data showing that epidural steroid injections is associated with elevated serum glucose levels for a period of time, which could be a problem with patients who have diabetes in particular. There's also some papers, as you know, that show that increased risk of osteoporosis, although clinically we don't see that as often as one might expect. But to me, this question begs another question, and it says, how would epidural steroid injection apply to a patient with nerve compression who was not resolved with surgery. It tells me that if surgery did not solve the problem, then the problem has not been well defined. And this is the single most important challenge when treating the spine is identifying the actual cause of the pain. A lot of times, as you know, the MRI will show abnormalities, whether it's nerve compression, disc herniation, disc tears, etc., arthritis, but not necessarily tell you the actual source of the pain. So if we apply any treatment, whether it's surgery or otherwise, to the inaccurate or incomplete diagnosis, then we're not going to have a good outcome with that treatment. So spines are particularly vulnerable to this challenge, and that's why you need to see someone who has advanced training, non-surgical training in the spine. Dr. Evangelista and I did spine fellowships. Dr. Ambach and Dr. Diaz, who work with us, also did fellowships in spine. So this is a highly specialized area. And even after treating the spine for me, almost 30 years, I admit to the fact that sometimes the spine is very humbling.
Yeah, in that scenario, if you're still having pain after the surgery, depending on where the pain is, like if it's a nerve pain down the leg that wasn't relieved by surgery, one, you want to make sure that there's not another source. But two, sometimes the surgery didn't really get the pressure off the nerve, and you may need a follow-up MRI to see if there's something structural still causing nerve compression that may not have been adequately addressed with surgery.
Yeah, the list of possibilities is actually quite long. I've seen patients get a discectomy, and then 3 months later, they herniate the disc above. So I agree. Having a low threshold to repeat the MRI, I think, is helpful. Doing a complete physical exam, obviously, is helpful. And then finally, understand that sometimes a nerve does not actually need to be physically compressed in a way that you can see it on MRI for it to be painful. We know that if the nerve is inflamed, for example, in the case with a disc tear, so if the disc has a tear, it's not herniated, but it has a crack or a tear, it can release proteins that produce inflammation in the area. That nerve is inflamed, the patient feels it, but you don't see it on the MRI. So there's many possibilities that need to be evaluated. Okay, next question. Another personal question said, I had numerous steroid injections in my neck. I had a spontaneous spinal injury that left me paralyzed. That sounds terrible. I'm sorry to hear that you went through that. Could the injections contribute to the injury? Extremely unlikely. There have been, unfortunately, cases where an epidural steroid injection in the neck produced a injury to the spinal cord. These are extremely rare. When they do occur, it's obvious. It's usually at the time of injection that the patient has this issue of paralysis. So, the question, I think, really is getting at, if I had many steroid injections, could that have weakened my neck to the point where I now have this other issue? And I think without really knowing the whole history and knowing what the imaging showed, it's really difficult to say. I'll only add that many times these conditions, these patients that we're treating with cortisone injections or what have you in the neck or low back for that matter, are serious conditions, serious disc degeneration, serious joint arthritis, serious stenosis, which can by itself lead to bad outcomes. Which leads to the next question. Is PRP effective in lumbar stenosis? What's your opinion, doctor?
It can be. That's a tough one because depending on how bad the stenosis is, if there is severe stenosis and just structurally not much room in the canal, PRP can only do so much to help that situation. So if it's mostly structural and it's just too tight in the canal, sometimes those patients need surgery to relieve pressure. If it's moderate stenosis, I think that's more treatable with PRP. We'll treat a lot of times treating the nerves in the canal, but we'll also treat the functional unit. So we'll treat PRP to the joints and the ligaments to help stabilize that segment. A lot of these patients have stenosis with a spondylolisthesis, where there's a slip of one bone on the other, so we can help stabilize that area with injecting PRP into the joints and the ligaments, as well as into the canal to help calm the condition down. So it can be effective depending on how bad the stenosis is.
I completely agree. Is hyaluronic acid better than cortisone for hip arthritis? There's some data on that.
I would say yes. I think cortisone probably gives you better relief right away, but it's not going to last. Hyaluronic acid may not give you as good of relief, but it's safer for the joint. So if you get relief with the hyaluronic acid, then it's better for the joint because it doesn't have that detrimental effect on joint cartilage. But hyaluronic acid is considered off-label for hip arthritis, so you'd have to pay cash out of pocket for that. And if you have to pay cash for an injection into your hip joint, comparing PRP to hyaluronic acid, PRP is superior to hyaluronic acid in most of the studies for knee, and so we would prefer that over hyaluronic acid for a hip joint as well.
I'm going to add one more comment, and it's a bit of a splitting hairs comment, but it's an important thing to consider as a physician and probably also as a patient. And that is, as we already explained, PRP can be made many different ways. There's more than 60 different ways of making PRP in the world with different centrifuge systems, different protocols. The same is true for cortisone. As you can imagine, there's many different types of corticosteroids. You have depomedrol, triamcinolone, celestone, etc. The same is also true for hyaluronic acid. So if you look at the very early data on hyaluronic acid, the outcomes were really not very good. And that's because they tended to use what's called a low molecular weight hyaluronic acid. Now things have become a little bit more sophisticated. They use a high molecular weight hyaluronic acid. There's also a thing called cross-linking, which is how the molecules actually stick to each other. So as you can imagine, a better quality hyaluronic acid, or hyaluronan is his other name, is going to produce better outcomes. That's what the literature shows, specifically in the knee, but probably elsewhere as well. So having that discussion with your physician, if I'm going to pay out of pocket for a hip injection to get this hyaluronic acid, which one are you actually using? Let's use the one that has the best chance of success.
Yep.
Okay, next question. I'm just going to read it because I haven't read it yet. So it says, my biggest issue is is a big person. They put their weight here. I have worked hard on my weight, which is awesome. That's probably one of the best things you can do for yourself. I've been getting cortisone shots in my knees for 9 years. Both knees are bone on bone. My pain level is it's high, 9 to 10. I'm guessing out of 10. I did have a knee ablation. So there's a different procedure that we didn't talk about here. Lasted for 4 months and brought the pain in half. So that's good. Is there any hope for me until I can lose enough weight to have the knee replacement surgery? Well, so the first answer, there's always hope, right? But the caveat to that, it has to be hope based on good evidence, right? So again, this is a case where we look at each person on a case-by-case basis. I've seen many patients who have severe arthritis on their x-rays. We look at their MRI. Sometimes we learn something new. We do physical exam. We learn something new. We identify other sources of pain that can be treated. The weight loss, we don't need to give a whole lecture on the benefits, but just suffice it to say there are many, many, many published papers showing that weight loss for obvious reasons in the knee, but maybe less obvious reasons. Why would somebody with shoulder arthritis also have improved pain when they lose weight? And it's because when we're overweight, there's a tendency for us to have more inflammation in the body in general, which contributes to that pain. So there's at least 2 mechanisms by which weight loss helps, not to mention all the other benefits that go along with weight loss. But yeah, so is there hope? I think this is a case where we really do you injustice by just giving a short answer on a webinar, and probably this would deserve taking a closer look at in the office. Can you see these, Ed, or am I?
Yeah. We have another question here. I have PMR, which I assume is polymyalgia rheumatica and psoriatic arthritis. Started methotrexate 20 milligrams per week and prednisone 5 milligrams.
Yeah.
I've had injections before diagnosis. can I'm assuming PRP help with my pain in hips and both knees? Yes, PRP can still help. I don't think PRP can help pain coming from the polymyalgia rheumatica, but if it's the psoriatic arthritis, there is still potential benefit for PRP to treat that. Would you agree with that, Dr. Rogers?
Yeah, I have treated patients with psoriatic arthritis, and it typically affects the little joints in the hands and feet, but it can also affect the spine and other large joints. And my experience with PRP in small joints is very good, whether it's osteoarthritis or other forms of arthritis, rheumatoid arthritis, for example. I don't know what it is about those little joints, but they seem to do better in general than even the larger joints, which in and of itself is quite good for mild to moderate arthritis. At least 92% of our knee arthritis patients improve with PRP, so it's highly effective. But even better for these little joints in the hands and the feet. Is that your experience as well?
Yes, I haven't done a lot of PRP for the smaller joints, but so far I've treated like the thumb, CMC, big toe MTP joint, and have had success with those.
Yeah, good.
Next question, PRP effectiveness for those who have had multiple Kenalog hip injections on the hip, 3 per year, more pain now, and probable cartilage loss, trying to avoid hip replacement. It depends on how bad the hip arthritis is. Hips are tougher. Hips don't seem to respond as well compared to knees, especially if it's at that moderate to severe stage of arthritis. So it really would depend on how bad the hip arthritis is. That's a common scenario. We see patients who get these repetitive cortisone injections 3 per year, and they work for a while, but eventually they're going to stop working and the pain is going to worsen. And that's usually at a stage where there's probably more cartilage loss and the condition is just worsened. But it would depend on how bad the arthritis is. I think if we're catching a patient with mild to moderate hip arthritis, that's definitely more treatable than someone with moderate to severe.
I think the other thing I should add here, and you know this, Dr. Evangelista, is that when we were younger, less mature doctors, we thought of things very black and white. We thought, oh, the x-ray shows hip arthritis, that's the cause of the pain. I think as we get more sophisticated and experienced, as we get older, we realize there's other things in there that can hurt. For example, I saw a lady today who had a tear of her labrum in her hip, some mild arthritis in the hip, but also some tears in her tendons around her hip. And to get the best outcome, you have to treat all those sources. And you can't just say, this is a hip arthritis patient. You have to say, this is a hip arthritis plus patient. And you're going to treat that patient differently than a patient who maybe only has hip arthritis, or a patient who has a very weak hip. Obviously you're going to add strengthening to that. A patient who has a very stiff hip, obviously you're going to have some physical therapy to mobilize that hip. So I think a lot of times these treatments don't just occur as a, one problem, one solution, but what I would call multimodal. Another example would be, say, this patient who's telling us about their hip, say we get an MRI. So a lot of times the physicians will order x-ray, but they won't order MRI. And the MRI will show lesions in the bone that you didn't really appreciate on the x-ray. And that's a very different animal. That's a very different problem, very different level of severity than someone who just has some, thinning of their cartilage. So, and there's some treatments now that we can add to that, that would address the pain that people feel from the lesions in the bone. So I look at each patient, if they have hip pain, look at the cartilage, look at the bone, look at the tendons, look at the ligaments, look at motion and strength, all these things, and then piece together a customized program based on what you find.
Next question, for severe hip degeneration, how much can PRP help, and do you use stem cells? Again, with the severe hip arthritic patients, those are tougher to treat. PRP is going to be less effective, and that's a situation where we may go to something stronger, such as a stem cell treatment. The only stem cell that we can use now with the FDA regulations are going to be your own adult stem cells. So using microfragmented fat, where we do a liposuction procedure and take those fat cells, which are your mesenchymal stem cells, and can inject that into the joint, or a bone marrow. We can aspirate your bone marrow, concentrate the bone marrow, which also have mesenchymal stem cells, and inject that into the joint. Those are stronger, will give you a better regenerative effect compared to PRP. So that would be a potential option if you didn't want to pursue hip replacement surgery.
Yeah, and that's something that we helped pioneer here at this clinic, where we learned a decade ago that there was a high number of these mesenchymal stem cells in the adipose tissue. Kind of a surprise to all of us, really, and developed techniques where we could translate those discoveries into actual treatments. And we've had good outcomes with severe hip osteoarthritis. I would agree with Dr. Evangelista's earlier comment that for some reason hips tend to not have as good outcomes as knee arthritis for the same level of severity. However, all you need is 1 or 2 patients to demonstrate, amazing results, meaning, better than 80% relief pain for more than 3 or 4 years from a single treatment, to make you realize that we have a lot more to learn about what severe actually means, and who's treatable and who's not treatable.
Next question. So if I had a cortisone injection a couple of weeks ago and now have a PRP scheduled for 2 weeks, is that going to be problematic? As long as it was we tried to avoid cortisone and PRP close together for about 4 weeks. So if the cortisone injection was 2 weeks ago and your PRP is 2 weeks away, that's 4 weeks, that should be fine.
Yeah, there's not a lot of published scientific data on this. There are some cases where patients who were taking oral steroids, which obviously commits higher doses over, person's taking a dose every day as opposed to a single injection. So you get much higher systemic level of prednisone in the body. There's definite data that shows that probably impacts the benefit of the PRP. But I used to be very strict. I wouldn't let anybody do a PRP injection for 2 months after a steroid injection, but I'm finding that was too restrictive and probably not necessary, because our outcomes, frankly, have been quite good. I'm not sure I fully understand it, because obviously the steroids can have an impact for quite a while in the joint, but nonetheless, the results have been good.
Okay. Next question. What is the damage caused to the shoulder by cortisone injections? I am told my rotator cuff is completely detached. I had surgery for a partial tear in 2009, and I have extreme pain now, and I've scheduled an injection next week. Well, again, as I mentioned in my talk, the cortisone can weaken those rotator cuff tendons. It will increase risk of surgery failing. So you can do a surgical repair, and there might be increased chance that the cortisone can weaken the tendons to a point where the surgery may fail. Cortisone, if it's put into the joint, can accelerate cartilage loss to the joint as well. So yeah, definitely we know that cortisone is not the best thing for tendons and joint cartilage. Now, if you're in extreme pain and you have an injection scheduled next week, that still may be a good idea to calm things down, but then you need to start looking about a longer term solution for that scenario.
Here is another point to bring up that I think patients should be aware of, and I think you would agree, Dr. Evangelista, is that my experience that in a busy orthopedic practice where you have these amazing surgeons that can repair the cuff, they kind of, not always, but oftentimes will shortcut the procedure. The procedure may not, the steroid injection procedure, it may not even be performed by the physician. It may be performed by the physician's assistant or by a nurse practitioner. And I think that's a mistake, because in particular, that person, whoever it is, whether it's the doctor, the nurse, the PA, should be trained in proper use of image guidance. So using ultrasound is a great way to assure that what you think you're injecting, you actually are injecting. You can actually see the needle. In the case of that patient with the full thickness rotator cuff tendon tear, the intention, I'm sure, of your doctor is not to inject steroid into the tendon. That's probably not their goal. They're either going to inject it into the bursa, where there may be some inflammation causing pain, or they may be injecting into the joint if they believe that there's arthritis and some joint swelling and joint pain. But if you want to make sure that needle tip is in the bursa or in the joint, you have to use ultrasound. Otherwise, you cannot be sure that that needle is where you think it is. And there have been cases, for example, where people get a vaccine, right? You get a vaccination in the arm, and they're not using ultrasound for that because, they're just jab you and go, right? And there have been cases where the person administering the vaccine has accidentally injected the vaccine into the tendon, and just the sheer volume that is injected can disrupt and damage the tendon. There have been cases of rotator cuff tendon tears with that. So if, obviously if you go lower, the chances of that happening are less if you inject the muscle, but that's been well documented. So the point being is, if anyone injects anything into my shoulder, they sure is better be skilled in using that ultrasound and look where that needle is going.
I agree completely.
Okay, next question. I think we answered some of these. This question says, when would you use hyaluronic acid versus PRP? It sounds like PRP is usually better for most things. I joke with my patients. I say, if I had a bumper sticker on my car, it would say PRP is better for most things. And that's because that, after injecting cortisone, how many years, doctor? I mean, we still inject cortisone from time to time, but it's probably less than 10% of our patients, I would say, maybe even less than 5% of our patients really need steroids. But for years, that's all we did, right? I mean, day in and day out, we'd come in and then we inject cortisone until we realized, oh my gosh, PRP is better for most things. And by the way, PRP is better than hyaluronic acid, certainly in the case of knee arthritis where it's been studied the most. And now that insurance doesn't want to pay for hyaluronic acid anymore, it's a no-brainer because the PRP is superior and the cost is almost equivalent.
Yeah, some of the data that I presented were comparing PRP to cortisone and hyaluronic acid, and the majority of studies do show that PRP is superior to hyaluronic acid for joint.
The only exception, you'll see 4 or 5 published studies, beautiful studies published in the Journal of American Medical Association, New England Journal of Medicine, very prestigious journals, where they will say PRP was not superior to corticosteroid or placebo. And if you read the details of those papers, you'll realize that they did not make PRP correctly. And when I say correctly, I mean the way most of us who've been doing this for 10 or 15 years, we make a PRP that has minimum of 5 to 10 billion platelets. The published papers that show PRP is no better than steroids, they made a PRP that had maybe 2 or 3 billion, so quite a bit less than the 10 billion platelets that we're using. And the platelets are manufacturing the drug. They're manufacturing the growth factors that stimulate the healing, decrease the inflammation. So in those studies, they were underdosing those patients, which is why they didn't get the outcomes that we typically see. Somebody said, thank you. So you're welcome. Thank you for your time. How are we doing? Oh, we've run out of time. Is there any question? I hate leaving questions unanswered. A quick question about stem cells, but we are out of time. We'll have another talk on stem cell therapy and what it is not, and when to do it versus PRP. But in a nutshell, it has become more accepted, and there's a lot of data to present on stem cell therapy. But PRP is not stem cell therapy. PRP is platelet therapy, a different kind of cell therapy that we think is very useful for our patients.
Yep. And last question, injections, we use ultrasound. Yes, absolutely. We use ultrasound or fluoroscopy to guide all our injections. So it's all under image guidance.
Yeah, that's critical for safety and for efficacy, but also for comfort. Procedure is very well tolerated when you use ultrasound guidance or X-ray guidance. I'd like to say thank you to everybody for taking the time to be with us this afternoon. And if you have any questions, you can find us on our website, SDOMG.com. We also have a YouTube channel that has about 30 or 40 or 50 videos like this one on it that you can watch. Just go to YouTube and type in SDOMG. And we have some other stuff probably that you can look at as well that Dr. Evangelista may know more about.
All right. Thank you, everybody.
Thank you. Have a good afternoon. Be well.
Bye.